Good morning, respected chairpersons, my esteemed seniors, colleagues and dear PGs. We warmly welcome to the Usmania Medical College and General Hospital. We are conducting Fistula 2025 under the guidance and of the Dr. Pallam Pravin sir. And myself, Dr. Muhammad Abdul Rehman, Associate Professor, General Surgery Department. My topic for today's conference is anal gland complex and its significance in anal fistula. So, anal gland complex and its significance in anal fistula is a theoretical topic, but it is very important to understand this topic before going to the management of fistula in ano. Introduction. Anal gland complex represent a crucial anatomical structure in pathogenesis of anal sepsis and related anorectal disorders. Anal sepsis include all the infective conditions like abscess and fistula. Anal glands are believed to the primary source of cryptoglandal infections. Anal gland provide avenue of infection from anal canal to submucosa or intersphincteric space. Knowledge about the anatomy and pathophysiology are essential for preventing the recurrent sepsis and fistula formation. Causes of fistula in ano. So, cryptoglandular causes, which are the most common. These are infective causes. Non-cryptoglandular causes, which are non-infectious and it are very rare. Their examples of this one are Crohn's disease, ulcerative colitis, tuberculosis, HIV malignancy, foreign body, actinomycosis, LGV, leukemia, penetrating injuries and infected episiotomy injuries. So, histological background. First reference of anal gland was given by Albert van Haller in 1751, independently first described by Chairy in 1878, Herman and Desvos in 1880 and later by Lockhart, Mummery and Harris in 1929. All above authors and researchers supported the theory of cryptoglandular origin of perianal abscess and fistula. Synopsis of their review was varied opinion in relationship of anal gland and anal splinter, internal anal splinter. Anal glands are homologous to scent glands in other mammals. They play a role in pathogenesis of fistula in ano and may give rise to tumors. They compare anal glands of humans to the scent glands of the dogs and cats. They found out that anal glands are absent in cats and anal fistulas are very rare in cats. They try to produce fistula in dogs, scent glands, and failed, but the fistulas are not uncommon in the dogs. They found out that fistula in dogs may be due to the scent glands in intersphincteric space, which are homologous to human anal glands. Johnson in 1914 described anal gland anatomy in detail. There are two types of anal glands. First type is simple tubular structure lying within the submucosa. The second type is branch glands which pierce the internal anal splinter and rarely penetrate the longitudinal layer but almost never involves the external anal splinter. Hill et al. In 1943 found a wide individual variation in number, depth and shape of the anal gland, thus explaining the individual susceptibility to the anorectal sepsis. Park in 1961 demonstrated anal gland involvement in the fistula pathogenesis. Original report from Park in 1961 shows that 8 out of 30 fistula cases display gross cystic dilatation of anal glands. 13 out of 30 shows anal gland epithelium lining in the intersphincteric space or fistula tract. 7 out of 30 had anal gland present which are not a part of fistula tract. He concluded that 90% of perianal fistula started from the infection of the anal glands. Elias in 1968 found that intramuscular anal glands are not found in all individuals. Schaffer and Kolik in their study of 52 infants with anal fistula noted markedly irregular and thickened dentate line. This theory implies the fistula in ano is result of congenital anomaly or preposition. Anat- Anatomy of the anal glands. Anal glands originate either from intersphincteric space or submucosa, and the ducts of this gland passes to the internal anal sphincter and empty into the floors of anal crypts. Anal crypts, which are also known as crypts of Morgagni, are small mucosal recesses located at the base of anal canal, anal columns, just above the dentate line. Anal glands are about 6 to 8 in number, primarily located in the posterior center, rarely in the anterior center, and none on both sides. Posterior location explains the reason for many of the patients having internal opening posteriorly. The ducts of these anal glands open into the floor of the anal crypts, and occasionally two glands open in the same crypts. About half of the anal crypts do not have any gland communication with them. These glands may be tubular or branch. Most of the submucosal glands are tubular and the intersphincteric glands are branch. Each gland will have 4 to 16 secondary or tertiary ramification going in different direction. These ramifications create a pathway for the spread of infection. The greater number of branches, the greater possibility of spread of infection. Gland extend outwards and downwards and never upwards above the level of anal walls. Length of the anal ducts is around 1 to 2 millimeters and occasionally 4 millimeters. Location of the anal glands, submucosal they are about 10 to 20%, intersphincteric space or grew about 80%, conjoined longitudinal muscle about 7 to 8%, external anal less than 1%. No branch of gland extend into the external anal sphincter according to the Park. Pointer. This is a figure showing the anal gland in submucosa and enteral space. You can So you can see that the anal gland is present and the duct entering into the mucosal anal recesses, anal Morgan crypts. The second one is histology of the anal gland. Anal duct is lined by stratified squamous epithelium. Gland is lined by stratified columnar epithelium with mucin, which helps to secrete the mucus, which facilitates the smooth passage of the stools. Anal glands are referred to the anal tonsils because of the presence of lymphoid follicles. The epithelial transitional zone represent a vulnerable area for bacterial invasion and subsequent infection of development. So next one is cryptoglandular theory of fistula formation. Abscess and anal fistula are anorectal suppurative disorder representing two phases of same disease. Anal abscess is the acute phase and fistula is the represent chronic phase. Steps of abscess and fistula formation. Initially there is an assault, trauma, obstruction, fecal impaction and stasis. Later bacterial infection, pathogen enters into the anal gland. Glandular infection, acute inflammation of the anal gland, abscess formation, pus collection in the mucosal plane or intersphincteric space. Extension spread into the adjacent tissue planes, fistula formation, development of chronic drainage pathway along the pathway of least resistance. In the phase 1, there is a obstruction and stasis. Fecal impaction or debris can cause duct obstruction leading to stasis and cyst formation, primarily if the affected gland produces mucus. This cyst is usually 5 millimeters in diameter. In phase 2, infection and abscess. The cyst may become infected and leading to formation of an abscess. You can see in the diagram there is a dilatation of the anal duct leading to formation of cystic dilatation of the anal gland. So this is the cystic dilatation of the anal gland. So phase 3, rupture of fistula. Cyst may become infected and infected material including bacteria, cellular debris and inflammatory cells accumulate in the lumen leading to enlargement and subsequent rupture of epithelial wall. These may lead to the abscess and subsequent fistula formation. The infected cyst may act as a nidus for the infection. So So this is the anal gland. So entering into the crypts of Morgagni. This is the infected anal gland in the mucosa of intersphincteric space. So if abscess is formed in mucosa, it may rupture spontaneously into the anal canal, leading to the subsequent fistula formation with no symptoms. If anal glands extend through the internal splinter, abscess may form in intersphincteric space and spreads towards the skin along the path of least resistance, leading to intersphincteric or transsphincteric fistula. Abscess may drain in any direction, leading to formation of complex fistula. So anatomical pathways of spread. The infection may spread through the following pathways: superficial or submucosal pathway, in between internal and external anal splinters, that is intersphincterics, across the splinters, that is transsphincteric or suprasphincteric, anteriorly after crossing the transverse perineal muscles, posteriorly toward the sacrotuberous ligament and gluteus maximus. So this is a picture shows there is a initially inflammation of the anal crypts, acute abscess formation. Once there is an abscess formation, this abscess may go in any direction depending on the least pathway of resistance. If it goes submucosal, it ruptures into the anal gland, and this is least symptomatic. And if it is comes down below subcutaneous, it is painful. And suppose if it goes into intersphincteric space, this is intersphincteric abscess and this is transsphincteric. So anyway, this abscess, it can follow any path: submucosal, subcutaneous, intrasphincteric or transsphincteric, and sometimes there will be extrasphincteric abscess also, leading to fistula formation. So types of anal abscess: ischioanal and ischiorectal. Ischioanal is the low anal, ischiorectal is the high anal. In the low anal abscesses, intersphincteric or transsphincteric. So simple fistulotomy or fistulectomy is needed for these two fistula abscesses. But whereas in the high ischioanal abscess, which has intersphincteric abscess, transsphincteric abscess, suprasphincteric abscess or extrasphincteric, we should be very careful when doing the drainage, because it may damage the splinters. So splinters saving procedures are indicated in high anal fistulas abscess. So E. coli and gut flora contribute to the infection and chronicity. Presence of enteric bacteria correlate with the fistula prominence. Most of the anal abscess contains multiple organisms reflecting polymicrobial nature. Chronic cryptoglandular infection is associated with the increased expression of matrix metalloproteinase, which degrades the extracellular matrix and facilitates the tracts formation. Adipokinase and inflammatory cytokines may contribute to the tissue remodeling and chronicity. Conclusion: anal glands are central to the fistula in anopathogenesis. Understanding the anatomy and pathophysiology is important in treating a fistula in ano. The number, size, exact location of anal gland can vary, influencing the pattern of sepsis and fistula formation. Deep-seated anal glands and those with atypical course may predispose to the complex and high anal fistulas. Anal gland rudiment should be destroyed by thorough curettage of the abscess cavity to facilitate healing of fistula and prevent recurrence. Understanding this variation is essential for surgical planning and to avoid recurrence and incontinence. Thank you.